This program is a presentation of UCTV for educational and non-commercial use only.
This is a quote that we thought would sort of pull together and include everyone in the room as potential beneficiaries of this talk. And it's from Rosalind Carter, who has a caregiving institute at Georgia Southwestern University. And she said, there are only 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. This slide is a quick review. As we talk about caregiving and we talk about strategies and we talk about emotions, some of those emotions vary based on the different types of dementia, so I just quickly want to give a little bit of background. As you've learned over the past few weeks, dementia is basically a syndrome that's characterized by loss of cognition and also loss of function. But there are several different causes of dementia, with Alzheimer's disease being the most common and responsible for about 75% of the cases. Vascular disease accounts for about 11%, frontotemporal dementia about 5% for Lewy body and the Parkinson's disease types of dementia, and others 4%, and those are things like Huntington's disease or Creutzfeldt-Jakob. And the main reason to include this is, just as I said, they do have some different symptoms and some different trajectories, and so the strategies and the interventions may vary a little bit, so we just want to sort of provide that as a background. So this is a slide to talk about sort of describing the magnitude of the problem. And all dementia numbers are a little bit more difficult to get, but this slide, the Alzheimer's Association does a great job every year of really trying to assemble a variety of statistics. So most of these pertain to Alzheimer's disease. And basically, 5.4 million Americans are estimated to have Alzheimer's disease. And of those, 5.2 million are age 65 or older. Obviously the majority, but that still leaves about 200,000 people who are under 65 with some very unique caregiving needs. They're still often working. There's still children at home. They are not eligible for Medicare. So there's a whole cadre of things that apply to that group rather than the over 65. 3.4 million are women, and 3.0 million, or the majority, live at home. The average survival for Alzheimer's disease from time of diagnosis is between 4 and 8 years, but some people may live up to 20 years and may spend almost half of that time in the more advanced stages of the disease. And I mention this more to give you an idea of the sort of ongoing quality of this type of caregiving. This is not a 6-month terminal illness that's very intense. It really has a very protracted caregiving period of time. And I don't know where the quote came from, so I hope I don't get in trouble. But I've been told that you describe this as a marathon rather than a sprint, and that you have to prepare for that. I think it's a nice analogy. 80% of the care that is provided in the home is provided by family, not professional caregivers. A little more information about the people with dementia that are being cared for. We know that they have a lot of, as many older people, have a lot of other illnesses. And Malone did a really nice study where he looked, in 2009, where he looked at almost 6,000 patients with Alzheimer's disease and matched them to 6,000 patients of the same age and education who didn't have Alzheimer's disease, and basically found that the people with Alzheimer's disease had a lot of other issues going on that would complicate their caregiving. For example, they experience more negative health events, they fall more often, and they're twice as likely to sustain a fracture if they fall. They're more likely to have infection, twice as likely to develop a pneumonia than someone without Alzheimer's disease. There is a greater utilization of psychotropic medications. So those are medications that affect your central nervous system and your thinking. Sleeping medicines, anxiety medicines, antidepressants. They're 9 times as likely to be on those medicines as people without Alzheimer's disease, which says that they have a lot of those complicating factors, and they're also susceptible to the side effects of all those medications. They're more likely to be hospitalized. People without dementia had 12% of them had a hospitalization once a year, whereas 24% of the patients with Alzheimer's disease had a hospitalization in a year. And finally, there are 2 older studies by Hill and Joyce where they looked at patients with Alzheimer's disease and patients without, controlling again for age and education, and found that they have much higher incidence of diabetes, high blood pressure, cardiovascular disease, and kidney disease, all complicating and adding to the things that the caregivers are dealing with. So who are the caregivers? 60% of caregivers are women, most commonly a spouse, and after that, daughters, followed by daughters-in-law. 56% of them are over 65, or over 55. 2/3 of them have less than a college degree. Half of them live in the same household as the person with dementia. Could be easier because they're nearby and they don't have to travel. Could be more stressful to be in the home all the time. 2/3 of them are married, not necessarily to the person with dementia, so they may be handling caregiving and a relationship and a marriage. And 26% of them have children under 18 living with them, sort of the sandwich generation. So they're caregiving and they're taking care of minors. This is another way to look at the caregivers, and you can see that the majority of caregivers for Alzheimer's, 70% of them are white. But again, as we talk about caregiving strategies and we talk about emotions, it's really important to put those in a cultural and an ethnic context. 15% of caregivers are African American. They're generally younger. The average age for African American caregivers is 48. They're usually single. They usually have less than $50,000 a year annual income. So different strategies and different supports that may need to be provided for that population. Hispanic caregivers make up 12% of that pie, and again, they're even younger. The average Hispanic caregiver is 43 years old. Again, has an income under $50,000 a year and is single, but also is much more likely to have children in the home, people under 18, and report a lot more stress trying to manage child care and caregiving. Asian Americans make up 1%. They're generally married. Equal numbers of male and female caregivers in that population. Most are college educated and they have a higher income. So different strategies and different supports for that group potentially. So just something to keep in the back of your mind when you're thinking about how best to support the caregivers. Some issues around occupation. 55% of caregivers are the primary breadwinners in their home, and 44% of them are employed. So these are not people who are necessarily retired or sitting home and don't have anything else to do. And it has a huge impact on their caregiving, on their occupation. 70% of them report that they have to go into work late or leave early. 21% end up taking a leave of absence from their job. And finally, 14% report that they have to turn down a promotion or reduce from full-time work to part-time work, which obviously has immediate and sort of downstream financial implications for retirement being put aside, job promotion. So definitely some significant things to think about. In terms of what care is being provided, this is again from that 2011 Alzheimer's report. 14.9 million family and unpaid caregivers provided over 17 billion hours of care in 2010 for people with Alzheimer's disease. That averaged out to about 21.9 hours of care per week, and when you calculate that at $11.93, which is the national norm that they came up with, it translates into $202.6 billion of care that was provided by family and unpaid caregivers. A smaller study looked at the amount of time that caregivers spend and found that caregivers spend on average 22.8 hours out of every 24 with the person that they're caring for. And I like a lot of people, but that's a lot of time to spend with someone. So in terms of providing care and what's provided, Alzheimer's disease caregivers are much more likely to spend time advocating, managing, and supervising care than are other caregivers. 64% in Alzheimer's disease as opposed to 46% in caregivers of other patients without Alzheimer's disease. Primarily, I think because of the cognitive deficits that are involved with this, people need someone to take over that managing and advocating role, so more likely to happen in these patients. Because this disease progresses over time and it occurs along a continuum, often the complex abilities are what are lost early and people may need more help and support with. So the complex things that caregivers may be providing early on and for a long period of time may be things like finances, transportation, managing medications, how to give them, how to reorder them. The more basic things that people provide may occur later in the disease, things like bathing, mobility, safety issues. How much supervision does someone with Alzheimer's disease need at any given point to remain safe? Might be a little later in the disease, but certainly still pretty emotionally and physically taxing. This is just another way to look at providing that basic care. Basically, on average, dementia caregivers spend about 48 hours per week providing this basic care, and other caregivers spend about 31 hours a week. And you can see the blue bar represents dementia caregivers, the yellow bar represents non-dementia caregivers, and you can see in each of those areas, getting in and out of bed, dressing, getting to and from the toilet, that the dementia caregivers are spending more time providing those services. So because a picture is worth 1,000 words, we have a video of a family that we work with at the Memory and Aging Center. This gentleman actually has frontotemporal dementia, but I think some of what you'll see both from his perspective and the caregiver highlights some of the things that we've been talking about.
I wonder where I put my cell phone. Oh, I'll just use my regular phone to call.
We need to get this in here, Practice.
Hi. Can you give us a heads up when you get close? Because Shenley'd like to videotape that as you all
Wow.
come in. Bob, just a minute. Honey, don't touch that. That's hot. You burnt your hand.
It's cold.
It's hot.
It's warm.
You cannot
It's
open
warm.
the oven and pull that out, sweetie.
Well,
Hot.
it's okay.
It's maybe okay, but it probably burnt your hand.
It's
Okay? Well, he might have burned his hand because he reached in the oven and grabbed the cookie sheet to take out.
So, you know, a couple things. You can see sort of, and this is something that caregivers talk a lot about, he's standing while she's trying to do things, talk on the phone, just sort of standing and shadowing her, standing right behind her. And then, in a blink of an eye, she's not 3 feet from him. He impulsively does something and suffers an injury, burning his hand, and it happened, you know, just when she answered the phone. So sort of that relentless sense of, boy, being on your toes at every minute. So, okay.
Great. Happy to be here tonight. We're going to talk a little bit about some of the background of the caregiving research that's been done, and I think in the field of dementia we actually benefit. Dementia caregiving has been very well studied, and in one latest analysis counted actually over 2,000 studies have been done focusing on dementia caregiving. We're not going to cover all 2,000 here tonight, so you can take a little breath of relief here. But this is a nice framework that we thought we could use to cover what's been really discovered about this research. And the first initial types of research on dementia caregiving focused on psychological and subjective outcomes, so things like stress and the emotional consequences, burden that occur with caregiving. The focus shifted then and added, looked at more physical effects on caregivers' health as a result of being a caregiver. And then the focus that we really see now is what makes up successful coping to caregiving. What are those issues? So things like resilience, perceived control, mastery are some of the concepts that are being studied now, because not all caregivers have negative outcomes. There's a lot of examples of caregivers that do quite well as caregivers, and it's tempting to try to figure out what are the ingredients that make up that success and how could we learn from those successful caregivers and then translate that information for other caregivers. So, and I want to explain the use of the quotes on some of our slides, or quotes from caregivers that we've heard over the years. And this was a daughter who was taking care of her mother with a dementia. And at a clinic appointment, we asked how the daughter was doing with the caregiving, and she said her answer was that she cried a lot. And there are a lot of emotional consequences to caregiving. And again, it's been a field that's been pretty well studied. Dementia caregivers tend to have higher rates of anxiety compared to the normal population. And the study cited here, Mahoney in 2005, looked at really what are those factors that are associated with anxiety in caregivers. And what they discovered was anxiety in the caregiver was linked to irritability of the patient. If the marital relationship was of a poor quality to begin with, the more functionally dependent the patient was, the more help, hands-on help that they needed from the caregiver, and then whether the caregiver actually rated their own health as being poor or fair, all were the factors that linked up to more anxiety. Depression is also a huge factor for caregivers, especially for dementia caregivers. And a meta-analysis cited here found that, looking at all the studies, it ranges anywhere from 30 to 80% of caregivers have depression, and quite a significant number have a clinically significant depression, which really means that they have a depression that warrants treatment. So medication, counseling, it really shouldn't be left alone. And depression looks like it's associated with some sort of unique factors as well. So if the caregiver perceives the workload that they're doing as a caregiver as being a high workload and high burden, that's linked to depression. Behavioral symptoms on the part of the patient, we're going to talk more about that in detail later tonight, are really associated with depression in the caregiver. Women tend to rate higher rates of depression on rating scales than men. I think we could have a long discussion about why that's so, whether women actually are more depressed than men, or maybe men have a harder time rating their emotional level on a survey. Maybe that's not the best construct to use. But that gender difference has been well founded in the literature to date. And then this idea of strain, which I think is really fascinating, sort of emotional and physical strain. So the feeling that you're sort of at your limit, that the demands that are on you exceed your resources, and you're sort of at your limit. And it turns out that physical, emotional strain in dementia caregivers is quite prevalent. And I want you to remember that, because we're going to talk about some other implications of that strain. I should also mention one other thing I had in my notes I wanted to mention about the depression, that another study in 2003, looked at the association between loneliness and depression. And so caregivers filled out rating scales with items such as whether they felt left out, whether they felt like they had someone to turn to. And the caregivers that rated pretty high on the loneliness scale, that was also associated with depression in that cohort as well. So we're going to move to some health consequences of dementia caregiving. A lot of this comes from that 2011 Alzheimer's Facts and Figures, and others of these findings come from some of the literature. Caregivers are less likely to have their own health insurance. They're less likely to engage in preventative health strategies, so they may not fill a prescription as readily due to the cost of the prescription. Over 70% in a lot of the studies report not going to a doctor's appointment, or not scheduling a doctor's appointment for their own health and directly related to their caregiving demands. 20% of caregivers in one study were cited as having fewer mammograms than non-caregivers. So again, I hope you're getting a sense that the burden and the time and what's involved in being a caregiver has this direct link on their health, because caregivers are often putting their own health and the importance of their own health sort of on the back burner. And then this concept of social support, which is that emotional and physical comfort that we get from others, that piece that makes us feel part of a community. If that's lacking for caregivers, their health tends to be worse too. So they have sort of this extra vulnerability. going on with some other health consequences of dementia caregiving, and I think the first three really point to that there is a physiological response to caregiving. And in studies looking at immune response to vaccines, looking at wound healing among caregivers versus non-caregivers, and then looking at things like stress hormones, cortisol, blood pressure, all of these are affected, especially in dementia caregivers. So they have impaired responses with their immune system. Wound healing takes longer, and they are also reported to have more conditions of new cases of hypertension and coronary artery disease. So there's a physiological impact from providing care. And then I think we also thought it would be important to talk about sleep disruption because it's a huge problem among caregivers. Over 2/3 of family caregivers have, in multiple studies, report some sort of sleep disruption. So either poor quality of sleep, insomnia, waking up too early, not being able to go back to sleep is a huge problem. And one of the effects for the patient and for the caregiver is that sleep disruption is one of the major reasons why people end up institutionalizing the person with dementia. Because it's just too hard to provide the care and sort of go on with your day when you're also sleep deprived and you can't count on getting a good night's sleep. So sleep is a big issue. And then I also wanted to just take the moment to mention some work that we've done with our caregivers, and in a sample of our frontotemporal dementia caregivers, they had pretty high rates of endorsing sleep disruption and poor sleep quality. We had a chance to measure their activity and measure activity and sleep over a 2-week period in a sample of caregivers and the patients. And the percentage of time sleep and the timing of the sleep pattern actually looked pretty normal. So again, it's sort of interesting and makes you think that a lot of the sleep complaints aren't necessarily as a result of the patient factor. The patient isn't waking them up, but perhaps the caregiver is lying awake because they're worried about the future, they're worried about the finances, they're worried about all the decisions that they have to make. And so I think it's sort of compelling and interesting to think about. So on this slide, we thought it would be really important to include, these are caregivers that weren't dementia caregivers. This was actually a really interesting study of almost 400 caregivers compared to a little over 400 non-caregivers, and it focused on cardiovascular disease. And the take-home point that I want to leave with you is here in the orange box. And really what this study is showing us, that if you were a caregiver and you reported strain in your role as a caregiver, you had a mortality rate of 33%, which made your mortality risk 63% higher compared to those subjects who had a spouse who wasn't ill. So it wasn't only being a caregiver, it was having that strain, the emotional and physical strain of being a caregiver that raised your risk for mortality. And the quote is a quote that we hear often from caregivers. And it could be any gender, but caregivers really worry that the patient will outlive them. And I think it's really, in talking to them, a lot of them is because they're really nervous and worried about the burden of caregiving, and they know that this is having an effect on their health. And they're also worried that if something happens to them, where's that going to leave this patient who needs this care? So lots of things to worry about. There are other objective and subjective changes that occur for caregivers, and this is actually some work on a paper on latent grief, and the way the authors define latent grief was this grief that sort of lies dormant, that it's waiting to be developed. And I think a lot of caregivers do feel this, that we gradually lose the person to dementia over usually a very slow amount of time. Some people describe it as sort of watching the person fade away. Spouses especially, but also children, feel that they're losing a person, they're losing the relationship with this person, and they're losing dreams, shared dreams for a future. So especially with spouses who are perhaps picturing their retirement years much differently, of traveling and being with friends, are now really dealing with a chronic illness that's progressing quite slowly over years. This process for the caregivers is ambiguous. As I said, it's slow. It's hard to know and predict when changes are going to happen. Caregivers will often ask us, well, what stage is he or she in? So I can, sort of project for my future? And that's a hard question to answer because there are no real definitive stages. You can kind of get a sense of where they are, how long they've had the disease, and sort of what symptoms they're showing to get a sense, but it doesn't sort of march along in a way that's sort of predictable, which makes it hard then for the caregiver to know what to predict. And then personal identity for caregivers. I have a lot of caregivers that have objected to the term of being called a caregiver. They feel like it sort of gives them sort of one designation, and most of us feel like we have sort of several different identities. We're not just one person. And so along with this latent grief is what the caregiver is going through in terms of their own personal identity. And they might go into medical visits and really they're called a caregiver, they're looked at as a caregiver, and people tend to really view them in that way. These same authors also looked at this concept of disenfranchisement, which I think the quote really captured. This was a wife of whose husband had Alzheimer's disease that I knew many, many years ago, and we started talking about their social life, and they had always had a very rich social life and lots of traveling and lots of very close friends, and what she noticed as part of her husband's illness was that these friends just sort of drifted away. And her comment was that you feel like you're a leper, but you don't even have the disease. And that she really said it really comes down to we really have very few friends that I can call on now. So that social support for them and for her had really shrunk over the years. And I think there's a lot of reasons for that. I think people have a hard time knowing how to spend time with somebody who has memory loss and who has word-finding trouble. They don't know whether they should try to finish the sentence for that person or not, if that's a help or if that's insulting. So I think a lot of it is natural that we're sort of worried and we don't know what our reactions are going to be, but the consequence for the caregiver is to lose those social connections. And also, a lot of families and friends have conflict over the actual diagnosis, and we've worked with lots of caregivers who say that the rest of the family doesn't believe that this person really has dementia. They think it's the wrong diagnosis. They think I'm just not getting along with him right, well enough, and so they really don't get that acknowledgement from their family. And while it may seem supportive, it's not helpful for them to hear someone say, well, there's really nothing wrong with her. He's fine, nothing has changed. When what they're dealing with on a day-to-day basis is lots of changes. Stigma is also a concept that's received some focus of research, and I think fascinating research. The Chinese symbol on the top is an older set of characters for dementia, and it literally translates to stupid and slow elder. So you can imagine the stigma of that and why people wouldn't want to confess that they had this diagnosis or wouldn't want to confess that a family member had it. The shorter character, the second one down, is the term that's used now, which translates to cognitive decline. But I think sometimes those stereotypes and those negative feelings are hard to shake. And some of the studies, I don't have all of them here, but again, just a few that I thought were the most compelling, that especially early stage patients that were just recently diagnosed, have confessed that they don't seek out resources for dementia due to the stigma of the title. I think our language can be negative, and it can, as in the Chinese example here, and it can also be vague. And I know sometimes it's for a good reason that we'll tell somebody, well, you have problems with your memory versus, well, you have a dementia. And I think we do that, for all the right reasons, but I think it also sometimes sort of furthers this, stereotype that if we use the word dementia, it's overly negative. And then patients have also said that they withdraw because they're worried that their memory loss is going to be visible in public, that their word finding is going to be visible, and they're going to be embarrassed by that. And then for the caregivers, there's this sort of secondary stigma that happens. So as the patient feels more isolated, the caregiver then gets more isolated. And I think maybe a lot of us feel that work in dementia, we feel that in many cases these conditions are much harder on the family than it is for the patient. And I don't mean to demean what the patient is going through, but often patients with dementia, if they have limited insight into the changes in their condition, it's really left to this caregiver, usually this one sole caregiver, to sort of carry the weight of all of this and to carry the concern for the future. So To summarize, maybe set the stage for talking more about what the caregiving issues are, it's nice to think about these stressors being divided into two major categories. So primary stressors are things really directly related to the patient, so their functional level, the type of behavioral symptoms that they're exhibiting, any concomitant conditions that they have that Cindy went over earlier. So if they have hypertension, if they have poor renal failure, which is going to affect how they might respond to medication. And then these secondary stressors, how the relationship is changing between the caregiver and the person with dementia. If there's family conflict, what are the occupational, the legal, and the financial issues that the family is struggling with, or all those secondary stressors. And we're going to use the behavioral symptoms as a point of focus to emphasize them for two reasons. One, because they have an extraordinary negative impact for the caregiver, and I think we think it's a really good way to illustrate how we can help caregivers by talking about behavioral symptoms. This next piece, we have about a 5-minute video clip that was taken from the movie The Forgetting, A Portrait of Alzheimer's Disease by David Shank. He was thrilled when we asked him years ago if we could use this clip to help teach people about the caregivers. So we have his permission to use it. I don't know if anybody here ever saw The Forgetting, but we just really like this clip. And what you'll see are a support group for caregivers, and in an adjoining room there's a support group going on at the same time for the patients, and so it kind of flows back and forth, but I think it'll give you a sense of what the issues are for the caregivers better than I can.
I want to welcome everyone to the Road Ahead support group. This is our first meeting of the new year.
Every family hit by Alzheimer's faces stress unique to the disease. To help face these pressures, Harry and Gladys each come to their own support groups.
Life is full of changes. So why don't we talk about changes? How have things changed in your family?
What bothers me a lot in dealing with this is the stress I feel if I go out and leave him at home. I always call him, and if he doesn't answer the phone, then I drop everything and go back home again. So that's the biggest change.
Do others of you worry about leaving your family member alone?
Yeah, I don't leave her. I drag her with me or palm her off to my daughter.
Drag her with you. Harry, has something happened that made you realize you can't leave her alone safely?
A couple of months ago, I had to take the elevator up to the doctor's office, and I got out before she did, and I thought she was beside me, and I looked, she wasn't there. I looked right behind me, and she wasn't there, and I looked and saw the elevator door close. There were 3 banks of elevators. I stood there, hoping that she'd get on the elevator and come back downstairs. And one gentleman came back down on the elevator with her. But after that, I make her get on the elevator first and make her get off the elevator before I do.
How do some of the others of you manage those scary times, the panic times?
I just rant and rave. I just keep praying for the strength to accept his personality, because there's a big personality change.
Caregivers are really doing the best they can to care for their family member. They do everything right, and the person still gets worse.
So how are the holidays? Guys, did kids come up, your daughters come home? And
the holidays.
we have very early stage to approaching dead middle stage. People who can not initiate conversation, but understand what you're talking about.
On the sand, and it sees us.
It would be like walking into a fog and not knowing what's there. Not being comfortable in the world that they were so comfortable in.
And if I go to the grocery store, I got into trouble. I was there 3 hours.
Overwhelming?
Very overwhelming because they switched the store around. I had to look for everything. I had to go to the meat, trying to figure out what I'm going to cook, how I'm going to cook it. I mean,
Gladys,
you don't have too much to do now around the house. Harry does a lot of your stuff.
Well, he used to. He don't now. He's lazy. I do most everything around the house now.
You are?
Really? Oh, that's
You just had to take things on, huh?
You be doing those.
How about Gladys, Harry? How is she?
She's still in denial.
Still
She
in denial.
maintains that the only thing wrong with her is me. If she could get rid of me, she'd be in perfect shape. And she never does anything wrong, and she knows where everything is except when I take and move it so that she can't find it.
And Harold does the same thing, and I'm the culprit. And so from day to day, from minute to minute, you just never know what kind of a mood swing they're going to be in.
My wife tells me I'm vegetating because I do sit around a lot.
There's a lot of times that I really absolutely hate Harold. And it's not even that I hate him, I hate what's happening to him. And then I feel bad about myself because I feel that way about him.
One of the quotes I read in the book, it said, "I'm not dying, I'm just disappearing before your very eyes." And I thought, that's what it is. It's like, and when you see that blank look, that's the worst.
The frustration, not knowing what was happening, and how the hell do you tell anybody that, even your family? I mean, how do you explain what's going on? They just...
In a way, I think it's harder on the family because they are aware from beginning to end. With the patient, eventually, they do lose the awareness, they lose the insight. But the family caregiver is the one who has to cope with the decline, with the deterioration as time goes on.
So this slide's really going to help frame sort of the rest of our discussion, which is there are successful caregivers. There are people who do this well, and there are things that we can do to help them cope. And this is just sort of a schematic that we're quickly going to go through some of the strategies that we try and work with people, and then talk a little bit about a clinic that we've established to try and implement some of these. The educational strategies, I think, people use the traditional ways of classes and videos and reading, but to think that this is really a new skill for people. Caregiving is not necessarily something intuitive or something that you automatically know how to do. So it makes sense that you would need some training and education about the disease, what to expect, what are the changes in personality and function and cognition going to look like, and how do I deal with those. So really spending some time getting people familiar with that. Also, skills that you need in caregiving. For some of the wives that we have who have never managed finances before, suddenly have to learn how to do that. We have men who've never made a meal before who now suddenly have to learn to cook and realize they're pretty darn good at it and like it. But it is new skills that you have to learn. So education is a component. Support strategies. You saw the support group. This is a really tough thing to do. So providing people support groups, providing therapy, providing counseling, providing people who've shared that experience to develop that social network that Jennifer talked about, the lack of impacting healthcare providers. The other thing is, a lot of people don't want to hear about support groups. They say to us, "Oh, I don't want to go and hear other people talk about how awful it is," or "I don't want to talk about how awful it is. I'm really a private person." And to encourage people that there's an awful lot of practical information that gets changed hands in support groups. "Oh, my husband did that 2 years ago, and this is what I did, and it worked great for me." Or, "I have a caregiver, and I only need them for 4 hours. Maybe you could have them for 4 hours." So to try and get people to think about going for some practical reasons as well.
And then really important for caregivers is just making sure that they have a great network for managing the patient's disease. And we talk to a number of caregivers, and they'll come up with problems that they're having or issues with the patient, and we'll encourage them, "Well, you need to talk to the doctor." "Well, I'm so uncomfortable talking to the doctor." And you really have to have a doctor that you can talk to and either has an expertise in dementia or is willing to get the expertise from someone else and consult with other people. And then self-care, preventative health practices for the caregiver, that we try to even make contracts with caregivers, that you'll promise that you'll call and you'll get your physical, within the next 3 months, those sorts of things, because their health is so at risk, and it's so important that they get something, that they have their care too. So we thought we'd describe a behavior management clinic that Cindy and I started a little over a year ago, really with the focus of dealing with the behavioral symptoms of dementia, and our physicians would refer patients to us, And really what it's evolved into is a clinic where we get referred for patients with behavioral problems, but really when the physician has noticed that the caregiver is really having a hard time and maybe not coping as well and is really struggling, we'll get referred to see them as well. And there is some good literature out there that show that nurse-run clinics are pretty successful. It's really difficult to do what we do in our nurse-run clinic to do in a traditional medical appointment that really has to focus on medication management, getting tests run, laboratory data, things like that. So it's a different kind of a model where we do a parallel assessment. I interview the family or number of family members that come into the visit about what the challenges are that they're facing, how are they dealing with those problems, what's worked, what hasn't worked.
And then while Jennifer's seeing the family or the caregivers, I usually see the patient, I interview them to get a sense of sort of where they're at, what they think is going on, how they describe their day, to get a sense of physically how impaired they are. Can they, be up and around, or are they pretty unstable and they might be at risk for falls? How impaired is their memory? Are they going to be able to remember things that the caregiver has told them, or is that not a realistic expectation? And then Jennifer and I meet together to try and come up with a plan that incorporates those 4 strategies that we talked about and present that back to the caregivers and the family, hitting on education and support and things about managing the patient's disease.
The other reason why it's important to focus on behavioral symptoms and dementias, they're pretty common. And no one patient is like the next patient, so it's a very heterogeneous condition. But this study looked at over 400 people with Alzheimer's disease across the trajectory of disease and rated the prevalence of these different sorts of behaviors. And we highlighted in orange the ones that occur the most commonly. So apathy, or that lack of drive and initiative, tends to be the most common behavior, but things like agitation, aggression, irritability, aberrant motor behavior are things like obsessions and compulsions, so pacing, things like that, and then appetite issues are another big behavior that caregivers have to deal with and manage. The average patient with dementia has 2 to 3 behavioral symptoms that will manifest through the course of their disease, so it's not just one. And it's a changing landscape. They're often unpredictable in how they show up and how they sort of manifest in the patient.
So we thought we'd talk about a couple of cases that we saw in the clinic as a way to sort of illustrate some of the strategies. And this was actually a couple that was referred by one of the physicians in our practice to us because he noticed that the couple was having a lot of problem on sort of a routine medical visit. They were arguing a lot. The wife seemed very frustrated. And so they were referred to us, and her sort of synopsis of this was that her husband was signing up for multiple sweepstakes and then gleefully running in the house and saying, "We're going to win $1 million." And so she had identified, when she met with Jennifer, sort of 2 major points, that she was really upset and frustrated by the fact that how come her husband couldn't tell the difference between these sort of eligible scams and really winning $1 million. And secondly, that every day they were having the same argument about these eligible sweepstakes and signing up. So we divided and conquered, and Jennifer tagged onto the relationship, some of the relationship issues that could be contributing, like he had always been in charge of the finances, brilliant businessman, had always been able to do those sorts of things. They had a very equal decision-making and discussion in their relationship. So they always talked about things like winning the sweepstakes. That wouldn't have been something they did independently. And they had a real huge trust and honesty piece to their relationship. I saw the gentleman, and he was certainly very physically fit, very socially engaged. His memory was very, very impaired. So from my perspective, probably wasn't going to remember the conversation that he'd had the day before about the sweepstakes. And now is at a point where sort of the logic of understanding the difference between all of these being eligible versus you're actually going to win $1 million probably was a cognitive skill that he didn't have anymore. So Jennifer and I tried to, we met with the wife and tried to present a new reality for her, and tried to give her a new conversation and said, how about if you just say, wouldn't that be great? We're going to win $1 million. And it sounds simple, but it was really very difficult to convince her that that was something that she was comfortable saying to someone that she had always discussed things with, always had told the truth to. We did try to convince her that it would be great to win $1 million, so it was really okay, it wasn't a lie. But that also that we were more worried about the emotion and the content of their time together, and to not be spending it arguing about the sweepstakes. He also, filling out the forms, he's practicing his address, he's practicing writing, he was very engaged with this skill. He walked back and forth to the mailbox several times a day, which is a positive outcome. He really wasn't at risk for falls. So we tried to get them to sort of have a different conversation and look at it a little bit differently, make sure he's safe, get him identification so that if, when he goes to the mailbox, he were to get lost, he would be easily found. And so sort of trying to present a different way to deal with it.
One other example of a patient and a caregiver that we dealt with in our clinic was referred because the patient was reported to have sort of this escalating aggression and being sort of physically threatening to the family, sort of shaking his fist. And really the problem was that the wife wasn't seeing it for the risk and the hazardous situation that it was. And this was her comment, well, that he would never hit me. You know, we've been married a long time, he's never hit me before. And so it really showed that she didn't have a really good understanding of the changes that he was going through, and that he was now capable of hitting out in sort of a rage. And sort of the factors was, when we finally pieced it all together, was that he had one specific thing that really made him mad, and that was when he saw his niece driving his car. Now, he could no longer drive, but it really bothered him when he saw somebody else in the family driving his car. And then also in the course of the interview, this sort of came up just sort of as an aside. There's weapons in the home. They happen to have some guns in the house. And so, again, it was really a large part of it was trying to convince the wife, based on some testing that Cindy did that he was actually far more cognitively impaired than the wife was sort of giving him credit for. She sort of still looked at him as sort of, you know, the man in charge of the house and capable of making all these decisions. And we were on the other side saying, no, you have to stop driving his car and disable the car, don't drive the car, give him the keys if you think that'll make him feel better, but make sure he can't drive the car, and the weapons have to come out of the house. And then we just spent a lot of time really going over his testing and try to get her to accept the fact that he was a different man than the man she had married. And that worked, you know, to some degree. But at least everybody was safe. So now we have a video, and of one of our patients, and we'd like you, just as you watch it, just think about whether this is a problem or not.
Or is that what we want? I don't think so, but we'll look to be sure. Yes. Nope.
So in the interest of time, we didn't think there was much of a problem. I mean, it's a little disconcerting to see this man wandering around the community and pulling garbage out and collecting it. Definitely a bit of a health hazard. But the strengths were that he lived in a small town, he had a very accepting wife, and he had lots of storekeepers around that knew him and his wife very well and sort of kept an eye on him and made sure he never wandered off of his direct path and didn't get a hold of something that was, you know, too hazardous.
And he was still able to be outside, walking around, you know, some degree of autonomy, and it's a good example of walking the line between autonomy and risk, which I think a lot of patients and families struggle with, trying to keep people as independent as possible but as safe as possible, and people make different decisions depending on which is more important at the time. This is a sort of table that Jennifer and I used to guide when we were trying to put together that packet of interventions, and trying to start with things that are the least invasive, the least restrictive, and then moving to things that are more restrictive if they don't work. So the first thing that we usually try is to alter the patient's environment. You know, what around the environment might work better for their functional and cognitive impairment at the time. Things that can be as simple as, you know, reducing noise so they're not distracted by several different things going on at one time. Taking things that are automatic cues if you don't want one to go out a door. Sometimes just covering the doorknob is enough of a cue to confuse them and say, oh, that's not a door, I don't need to go out. Some of the behavioral strategies, you know, are there things we do or don't do that make the behavior worse? So really looking at how you respond, and are you making it better or making it worse?
Pharmacological interventions we definitely rely on, and the example I gave of the man with all the aggression and the anger about his car, that was actually one of the interventions, is that we had to, with the help of his doctor, increase one of his medications to try to reduce some of his anger and his responsiveness. So they definitely have a role. The issue is that, well, I'll go into that more in the next slide. Physical restraints we really don't use. We really know that they're associated with a lot of negative consequences for the patient. We always debate about whether to put secure lock facilities on this category, because the advantage of a secured facility is that it's locked, but the person can wander around freely to a certain extent. So a lot of really good facilities now have wander gardens where they're secure, the patient can't wander away and get lost, but they can wander outside in a garden setting without any difficulty or any risks. And then again, I think we've brought up to the sort of fifth category. There's lots of interventions that you have to do with the caregiver. They're sort of unique and internal to them that really, in large part, have to do with acceptance and acknowledgement for what the situation is. So as promised, why not use medications? It's a question we all get asked a lot. Isn't there some medication to make this all stop? And in a lot of cases there are, but in a lot of cases there aren't. There's no medication to prevent somebody from wandering unless you want to put them in a coma, but there's a lot of risks to that. And then it's also, we think, very helpful. The behaviors are a really helpful window into what the person's reality is. So if a patient with dementia hits us away, then maybe they're in pain, maybe they're overwhelmed, maybe they don't remember who we are, but it's a really helpful clue. And so it's not always negative, and so it's nice sometimes not to think that we just have to medicate away all of these behaviors because they're a window.
This last video is a video of the couple that I've been working with for a long time, and the gentleman relocated to an assisted living facility and was having a really difficult time allowing the staff in the facility to help him bathe. And his wife gets all the credit for this. She was a real hero. She's been incredibly creative. She goes twice a week. She wears a bathing suit. She gets in the shower with him. They've got bright towels so that look like home. They have matching bathrobes that they wear like they're going to the spa. So I just want to share a little bit of that for you.
Close your eyes. I want to put this on your head. I think I've got that side all done. Close your eyes. Close your eyes, darling. Close your eyes. It feels good, doesn't it?
So before this plan was devised, he was refusing to shower and hitting at his caregivers. And one of the benefits of doing these videos is that the wife watched the video and she said she learned even more. So she sort of thought the walk down the hallway to the shower was sort of lonely, a little bit ominous. So it was lighter when they were walking together in their matching bathrobes. And she also said, well, we were just talking too much, and we need to not talk so much at him. We were confusing him. And then she also realized that he really liked to shampoo his own hair. So rather than wait to do that at the end of the shower, just do that at the beginning. He's enjoying washing his hair, and then they can wash everything else. So we're starting to try to incorporate the use of video in our clinic because we found it's been a really helpful tool to identify some of these factors.
So we are running over, and we want Dr. Levinson to have time, but we want to sort of close with this then, which basically says that, you know, there are some very positive aspects to caregiving. Many, many people feel very satisfied with the job well done, and the quote was a gentleman who had been caring for his wife and said, "She always took such good care of me, now it's my turn." So people do get a sense of satisfaction from caring for people, learning new roles and responsibilities and succeeding at them that we talked about, and many people do have a spiritual influence, feel that this is their mission or that something that they need to do, and so it's not all bad.
I know we have more slides, but we're going to let Dr. Levinson go next and talk about emotions, and we'll be available for questions too.
Thank you. Well, it's really, as you can tell, just an honor to be on the panel with Cindy and Jennifer. I did my sabbatical about a decade ago at the MAC, and Jennifer was the person I think really who introduced me to this whole area of dementia. And then last year we started getting very interested in caregiving, and so we've been planning some research in that area as well. What I'm going to do today is I'm going to talk to you about that thing that kept on coming up in Cindy and Jennifer's talks, emotion. And I'm going to talk about it from starting from the perspective of what it is and how you study it and what we know about it. And then I'm going to kind of walk through and talk about how it plays out in caregiving. So my talk is going to be about four things: what emotions look like and what they do, how they can make us ill, how illness can change our emotions, and in particular I'll talk about a form of dementia that we work with that really targets our emotional life. And then I'm going to talk a little bit about what role emotions play in caregiving and what we might want to do about that. Okay. So I always like to start and show you what it is that I study. This is a person in my laboratory, and they're watching a video monitor, and this is actually facing them, and this is a picture of a man being very still. He used to be on the faculty here in psychiatry, and he's an expert on being very still. And she's going to hear a sudden, unexpected loud noise.
Oh, geez.
Now let's look at another person, same stimulus. And she's going to have a big emotional reaction. Okay, so that's what I'm going to be talking about today. And these emotions, they're very short, and they kind of occur in waves, about maybe lasting 3 to 10 seconds. We have hundreds of them every day. They're there to do us good. In this particular case, the emotion that she's having is essentially one that prepares her to deal with this threat. So she scrunches up and covers up the soft parts of her body and closes her eyes. This is wired very deep in our nervous systems. One of the interesting things about these emotions, for lack of a better term, is they're reentrant. That is, initially both of these people had this very protective response, and then they had a response to having that response. The first person was sort of amused. The second person was just sort of mortified. So in normal life, our emotions occur in these very complicated chains, and the most potent source of emotions are our interactions with other people. And since other people are having emotions as well, a lot of our lives become wrapped up in this kind of elaborate choreography of emotion, response, emotion, and response. So these things are ubiquitous, and we don't even notice them, and yet they are very, very vulnerable to disease and very important for our well-being. Now, what do they do? Well, in that little example, the first thing that emotions do is they signal others. So these are the famous 6 basic emotions that Paul Ekman studied. And so when somebody looks like this, you know, You know lots of things. You know that something that you did probably didn't go over very well, and you know that she might be about to do something that you really wish she wouldn't. On the other hand, here's a person who is not going to harm you, but a person who you may want to reach out and comfort. So these emotions through the face and the body signal our other members of our species and really communicate what we feel and motivate their behavior. They prepare us for action. One of the things that emotions do, they have huge effects on the brain. So if you've probably had this experience, maybe someone in this room, where you kind of get angry at a loved one, and all of a sudden the world shrinks, and the only thing you can see is that thing that made you angry. Well, emotions have this huge effect on our attention. When we are in the throes of emotion, we tend to favor time-tested solutions. We're not very creative. We do things like we run and we hit and we scream. And they also are links to memory. So when something makes us sad, like a movie, it's very normal for us to access all sorts of memories of loss in our own life. And in fact, that's one of the, in a way, the great pleasures of our emotional lives. We like to exercise them. So when we're young, we go to horror films because we like to be afraid. And when we're older, we go to touching movies. And at all ages, we go to romantic movies because love's an important emotion, too. Probably not getting your money's worth out of that. You probably knew that already. The part of the body that really prepares us for action are the autonomic and somatic nervous systems, and these are very important parts of emotion. So the autonomic nervous system is things like the heart and the lung and the liver and the kidneys, and the somatic nervous system are the muscles. And so motion is a big part of emotion, and not only do our muscles change and to help us fight and flee and comfort, but our bodies change in profound ways. Emotions also signal us, and I think this is a very underappreciated part of what emotions do. This internal experience of emotion is extremely valuable information for us. Sometimes we become aware of our bodies, the kind of the inner sense, the gut feeling, long before we become aware of what's making us emotional. Have you ever had the experience of walking into a room, going up to a stranger, and just kind of instinctively knowing that that person is dangerous? Or, conversely, that person is really someone who's could be very helpful or a friend. We sometimes, our bodies get agitated in ways that signal us that, that something important is going on and cause us to stop and take notice. We think that a lot of that subjective emotional experience is the byproduct of these changes that occur in our muscles and in the organs of our autonomic nervous system. And if you don't believe that, you can later on you can try this little experiment. Describe to your partner what it's like, what it feels like to be angry, but don't refer to any muscles or any parts of the body. Emotion is really about these bodily responses. Okay, so that's sort of what they do, and as I said, they're wonderfully helpful. So how can things go wrong? Well, when we think about how emotions might make us sick, usually we're talking about this bodily part of the emotional system. We normally don't get sick because we have too many facial expressions, but things can happen with these somatic and autonomic changes that can become the bridges to illness. And so I'm going to talk about that now, how emotions can make us sick. There are three trouble spots in the physiology of emotion that can be problematic: activation, regulation, and coherence. We'll start with activation. This is another fellow in our laboratory. I'm going to keep this small so I can kind of talk. And he's in a classic psychology experiment. He's watching this movie, that's what he's seeing, and in it a fellow is working in a wood shop, and there's no sound, but he's working without the guard on the saw. and soon he's going to cut his hand. You might as well look at it because some of you will feel an emotion. Okay, here it comes. Okay. All right. And now you see him, and he's going through those waves of emotion. Now, some of you laughed, and some of you, you know, probably felt disgusted, but a lot of you had emotional responses to it. So one of the things that we can do is we can look inside his body, and we can see what's happening when he sees this hand being cut, and that's right at this black line. And this green line is the activity of his sweat glands, and that's a very important part of the autonomic nervous system. And you can see that almost immediately when the hand is cut, he has this very dramatic increase in the activity of his sweat glands. Now, this red line is the activity of his heart, and you can see that in the period leading up to the accident, it's pretty, you know, the heart does that. It kind of goes up and down with breathing. But then when the hand is cut, it sort of goes up too. And the heart is kind of like the emotion itself. It sort of goes in these up and down waves. This is the nature of emotion. It activates these bodily responses. Now, how can this be troublesome? Well, we think that if you have too large physiological responses, that if your emotions are overwhelmingly powerful, and instead of producing these sort of small perturbations of physiological response, you start producing very large ones, those can set off a cascade of injurious changes. So in the cardiovascular system, you can actually produce damage to the linings of your blood vessels because of the sudden increases or very profound increases in blood pressure. The system is fine if it only happens occasionally, but if it happens chronically, so if you spend a kind of an emotional life which creates the equivalent of chronic hypertension, you're going to start to exact additional wear and tear on these very vulnerable parts of your body. Regulation is the second way that physiology and emotion can get you into trouble. This is not as intuitive. This is sort of how an emotion works. Something happens in the world, something in our brain makes sense of it, so we hear a gunshot, and somewhere in our reptilian brain, it's appraised as, that's not good news, that's sudden loud noise. And then you have this facial, motor, and autonomic response that we saw. So humans rarely just have emotions. They almost always try to adjust them to fit the demands of the situation. One of the best ways of regulating your emotions is just to change your attention. So if I tell you, I'm going to show you a man who cut his hand, some of you just looked away. Really good strategy. And one of the ways that therapists train us to sort of regulate our emotions is to think about things in a different way. So instead of thinking about your driving exam as sort of this horrible obstacle that you have to overcome, you think about it as a challenge. It's an opportunity to show your competence. And you just do this mental gymnastic, and all of a sudden something that might seem threatening might seem less so. And we find, well, this might be good news, we find that as we age, we get better and better at that strategy. But the other way that we often do this is we just sort of clamp down and we try not to let the emotion show. And this can be particularly relevant when we're dealing with caregiving. Strong emotions occur. We don't really see them coming. We powerfully don't want to show them because they might signal something we don't want to signal to a loved one. And so we just try to suppress them from showing, and we kind of try to put a poker face on. This is the way we do this in the laboratory. We show people, I think I won't show you this film. I'll just tell you about it. It's a surgical procedure where someone has an arm resected. It's quite gory. And in one condition, we tell people, just watch it. In the other condition, we say, watch it, but act so that somebody watching you wouldn't know you're feeling anything. So we have them hold back the emotion. And then it turns out that people are really good at this. So in the watch condition, if you look at how much disgust behavior that people show, they show about a half a unit of disgust per second during this film. And when we tell them not to show it at all, they basically eliminate it. And we're all very, very good at this. This is one of the things we don't get worse at with age. People when they're 80 are as good at it as when they're 18, doing this particular thing. Now let's look at the inside their bodies and see what the cost of this is. So this yellow line is the cardiovascular response to watching the film, okay? Just watching the film. The red line is when you watch the film and you don't let it show on your face. Okay, so I don't have to give you a lecture about autonomic physiology. You saw that right away. When you hold back the emotion, the physiological response of the cardiovascular system is much larger, and it stays up even when the film is over. And now this other one is the same thing with the sweat glands. And in this case, when we first tell them that they're going to have to shut down this response, they start becoming more aroused. The general rule of thumb from studying almost 1,000 people in about 5 studies that we've conducted over the years is that if you have X physiological response to having an emotion, you have 2X when you suppress the expression of the emotion. It's twice as hard, it's twice as big, it's more difficult, it's harder on your body. So doing that strategy of holding back your emotion may have the benefit of not signaling what you're feeling, but your body is paying the cost. Interestingly, if you use the appraisal strategy, which you don't always have time to do, if you think about things in a different way, that doesn't incur the large physiological cost. And of course, if you just ignore it completely and never see anything, you have no emotional reaction, but that's probably not a good way to run your life. Okay. So regulation can lead to trouble in 2 ways. One, you can underregulate, and your emotions can hurt other people. And the other is you can overuse strategies like suppression, and you can pay this powerful physiological cost. Now, this is one of the interesting things about emotion. It's a little esoteric, but I think it's worth thinking about because it's a real danger sign. Normally, I don't know how you think about it. If I asked you, do you think your emotions are chaotic or are they organized? Well, it turns out they're very, very organized. That when you have an emotion, there's a remarkably tight choreography that occurs from different parts of your nervous system. So remember, we looked at this one before with the fellow who was in this study, and we looked at his heart rate and his skin conductance. Well, now we're going to look at his facial expressions as he's looking at this accident. And there are 3 that occur where he has these kind of powerful eruptions of facial response. And you'll see that they line up very nicely with the beginning of the physiological response and these 2 peaks in heart rate. So it's almost as if the face signals the beginning of the emotion, and then it's like remember the pressure cooker with that little steam valve at the top? It's kind of like that. At the height of the emotion, the face fires again and kind of releases some of the tension, and then you cool down and it happens again. Well, you know, you don't think about this kind of elaborate coordination going on inside your bodies, but it is every time you have an emotion. So that's an emotion that's working right. It's like a factory in the just-in-time model. You want to have the expression, the experience, and the physiology all arriving just at the perfect time to deal with whatever it is that's causing you to have the emotion. So it turns out that when people get sick and they have emotional illnesses or physical illnesses, one of the things that breaks down is this kind of organization. And researchers have found that the higher the coherence is between the different parts of emotion, the greater the well-being, the quicker people recover physiologically from negative events, and that low coherence among these different parts of emotion has been associated with a number of anxiety disorders, with problems with identifying emotion, with schizophrenia, and with coping styles where you sort of hold everything back. So in a way, we can get a kind of a readout, if you will, of the health of your emotions by seeing how organized they are. And one of the things that we study in our dementia patients is whether or not this coherence holds up. And of course, needless to say, in dementia, you see this kind of breakdown in the different parts of the emotion system. All right, so that's the story about emotion physiology and some of the trouble spots where, at least in theory, we could see problems where emotions make us sick. So now I wanted to share you some actual data from a study that took us 20 years to do. We just finished this year. We have people come to our laboratory and they talk for 15 minutes about something in their marriage. And one of the things they talk about, they have 3 of these conversations, is something that they disagree about. And as you know, in all marriages, some rain must fall, and everyone has at least some area of disagreement. And while they talk about these things, we videotape them and we record their physiology, and we later show them videotape, which Jennifer was talking about, which turns out to be a very powerful and useful clinical tool. And we finished this study where we had people come back to the laboratory every 5 years for 20 years and talk about problems in their marriage. This is the kind of crazy stuff that psychologists do. I never thought I'd finish this study, but you know, there it is. And now we have this treasure trove of information that enables us to ask questions like, can emotions make us sick? And so I'm going to share you a new finding that's unpublished, where we look at whether or not anger really can make you sick. And that's, of course, one of the big ideas in thinking about emotion and illness. So this is a study which is asking what's the long-term effect of this. And we looked at the amount of anger in 1989, and then we measured their health every 5 years, and we controlled for all the things that one controls for in this kind of research: their age, their education, their general health promoting behaviors, alcohol use, and how unhappily married they were. And the results were very interesting. If you looked at the amount of anger in 1989, couples with a great deal of anger in these interactions had a 1.5 time inflated risk ratio for developing cardiovascular symptoms over the next 20 years. There were no differences 20 years ago in terms of the state of their cardiovascular system, but this anger was sort of a time bomb that worked to develop these symptoms over a 20-year period. And it's interesting, and I think this was impressive to us, it's not any negative emotion. It was anger. So sadness and fear, they didn't have this relationship, and it was specific to the heart. Other physiological symptoms didn't show this kind of risk. And this is what it looks like over time. These are the people with the high anger behavior at time 1. You can see at time 1 the groups are the same. And then over the ensuing years, they develop more and more heart problems. And it's the same for wives and for husbands. And interestingly, the most powerful effect is for the person who shows the emotion on their own health. So, you know, you can start to see if you're dealing with a situation where you're filled with anger and you're feeling it all the time, or if you're holding it back all the time, it can have huge consequences over time. All right. And I want to talk just briefly about the implications for caregivers. So if you're following at home, this is all the way towards the end. Jennifer and Cindy both in their talks told a basic truth, and that is that all the research suggests that as a caregiver, changes in the patient's behaviors are really, really difficult. When patients become emotional, when they have powerful negative emotions, when they become emotionally distant and cold, when their personalities change, and of course our emotions are a lot of what makes us who we are, these are a major source of caregiver burden. But also, caregivers have strong emotional reactions to the issues that they're dealing with, and I think you saw that very vividly in that caregiver video. We've been thinking, this is some work that Jennifer and I have been doing together, we've been thinking about some of the things that happen in caregiving and some of the emotions that they may produce. And I'm going to take it, just speculate one more step, and that is some of the things that this might lead to. So one of the things that's just built into caregiving with dementia is uncertainty. You don't know really what's going to happen you don't know the future, you don't know the pace, it's really hard for anybody to say exactly what's going to happen and when. And I think uncertainty is a primal antecedent for fear. So it's not surprising that one of the major problems that caregivers have are anxiety disorders, because fear is a big part of caregiving. There's also a sense of loss of the person you knew, a loss of function, a disappearing quality that we saw in that video. And humans are hardwired to respond to loss with sadness. It's the emotion we have. It's also probably not surprising that the incidence of depression is so high in caregivers. There's a lot of frustration in caregiving, and this can sometimes be very difficult because the response to frustration is anger. And anger is one of these emotions that, at least in our culture, it's really almost not appropriate to show, especially when around someone who's sick. And you saw that in the video, the person who said how angry they are. So anger, I think, is particularly problematic because if you act on it, we've just shown you some data which says, an angry life can be one which you pay a large cardiovascular cost for. Anger can also be something that's if you hold it back, it can be very dangerous. And of course, if you act on it, you have the potential for harming others. So this is an emotion where there's no easy solution. And if you have the kind of caregiving situation where there's a lot of frustration and a lot of anger, it's the kind of thing you're probably going to need help with. One of the things that Jennifer and I have been thinking about is that, not every caregiver has. There's probably a profile of these problems that differs for different patient-caregiver pairs, and we might be able to design treatments that are not so general, but are geared to these specific emotions. So psychotherapists, for example, have lots of good treatments for fear, for treating phobias. They're very different than the ones that are used for treating depression and sadness. And the same thing with pharmacology. So we're thinking that this kind of specificity might be useful. Inappropriate behavior often leads to emotions like shame and embarrassment in the caregiver's part, which can lead to dropping out of the social world, and we know that social isolation carries with it huge health risks. And then there's a sense of guilt that goes with caregiving, a failure to protect. And guilt can be a very corrosive emotion. And again, so these are some of the things that we're starting to think about, ways of measuring these precisely and understanding, in particular caregiving situations, which are the emotions that are most troublesome. So I'm going to stop and take questions. The question was, what about meditation? And there are a lot of projects now that are using this mindfulness-based meditation as sort of a very effective way of kind of recentering and settling the troubled mind. I think the data are pretty good that it has a beneficial effect. We just published a paper from my lab, which is kind of, I think it's interesting, where we show that people who are long-term meditators have greater coherence among these different aspects of their emotions. And we think part of it is because they become more attuned to their bodies. Now, there's also a downside to meditation. There are some findings that suggest that long-term meditators who become sort of hyper-aware of their bodies and their emotions are much more prone to poor reactions when they run up against difficult things in their lives, because they're mindful of both the good and the bad. And so the bad can be powerfully impactful. So I think that the verdict is out in terms of, the use of meditation in dealing with something as difficult as caregiving with dementia. I think there are all sorts of benefits for it, but whether or not it's going to be an effective treatment is going to probably depend on the kind of, again, the specific kinds of problems that you're dealing with. So if a caregiver is very agitated, probably this might help, but there is a cost, a potential cost. So we have 2 questions about coherence. One, what is it? And second, have we looked at heart rate variability? So coherence is the correlation between the different parts of the emotional response: the physiological part, the experiential part, and the behavioral part. But also, sometimes people have looked at the correlation between the different physiological systems, which is probably the question that you're getting at. We are saying that in general, the more these different parts of the emotion are in synchrony, the healthier the person is. And it's a kind of an early warning sign of emotions where they're either suffering from psychological or physical health problems. Now, heart rate variability is a particular measure that's of interest because it reflects the parasympathetic influence on the heart and is thought to relate to positive emotional states. We mostly find the relationship with, not with variability, but with actual heart rate. I think you're exactly right. The study that we did, we had people talk about problems in their, things that they disagreed about, so it was a hotbed for anger. But my guess is if we had them talk about uncertainties and insecurities and the anxieties of life, that the amount of fear they showed would be associated perhaps with gastrointestinal symptoms. This is an old idea in psychosomatic medicine that each emotion sort of targets a particular kind of organ system, and there's very little good data of the kind, like we're trying to collect where you look forward over time. But I think your hypothesis is probably right. I don't know anything that definitively proves it, but it certainly is consistent with, I think we would all agree that fear feels different inside you than anger does, and it does tend to be much more you experience it in the butterflies in your stomach. It's the classic metaphor.
And one of the things we didn't get to is we want to talk a little bit about the future of caregiving and the use. There's a slide. The use of social media. I think we're going to see that more and more, and it's a great way for people who can't maybe come to a physical location but still get that support. And the example that we put in the slide was care pages, which is a way for people to communicate around an illness or a condition. And there are other developments of looking at calendar systems. It's really hard, I think we mentioned earlier, for caregivers to ask for help. So now there's some internet calendar systems where the caregiver could just list what sorts of tasks they need help with and a schedule, and then friends and family can sort of log on and put their name down so that you don't have to do all that asking and all that talking back and forth. So I think social media is going to, we're going to see more and more use of that for caregivers. So thanks for bringing that up. I think we're getting the sign from Kyle, so thank you very much.